Good evening, ladies and gentlemen. Welcome once again to another interesting episode under the aegis of Mumbai Hematology Group. And the topic itself shows how interesting this is going to be. 10 things that a hematologist must not do. And this is going to be a quiz-based program. And to do this honor, we have none other than Master himself, Professor Dr. MB Agarwal. We all know him, but just to formally introduce her again, Professor and Head Department of Hematology at Bombay Hospital, also Senior Consultant Hematologist at Leelavati Hospital and Bridge Candy Hospital, Bombay, has been past President of Mumbai Hematology Group and also ISHPT. Sir is teacher of teachers, an institution in himself, and we are all grateful and fortunate. I was just discussing with him today, and this must be 250 plus webinars in last 2 years plus. Thank you for keeping us engaged, sir. No wonder that you have been awarded the Inspiring Hematologist of India. And also, a warm welcome to all the discussants, expert discussions today. I know all of you are going to make it very lively and very, very interactive. May I request Professor Dr. MB Agarwal, sir, to take it forward from here.
Thank you, Dr. Manoj. So good evening to one and all. And if you are from some other part of the world, good morning, good afternoon. I do know that people from 25 countries have registered. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS, managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, not only for this webinar, but throughout last 2.5 years, very aggressively supporting our academic activities. And that's what they've been doing for last 20 years with Mumbai Hematology Group. Mr. Yash, Kalpesh and their team from Perfect Square for flawless organization and conduction of all these webinars. We are relaxed because they work hard. The Executive Committee of Mumbai Hematology Group for giving me free hand in conducting these. You all discussants who are there present with me here, who are going to make this program so lively and going to share their experience, which is so important. And lastly, you participants, for sparing your Saturday evening or morning or afternoon, I request you to actively participate because this is an MCQ based and a quiz based program in which each entity, there will be options for you to vote. So if you actively vote, we know what the pattern of thinking is around. And then of course, our galaxy of these stars present over here will give their views. We have the Mumbai Hematology Group has its website, and that's where you can go and visit and see our past activity and the future activities. So if you want to know what is the subject of the webinar tomorrow, day after, next week, that's the site. Very simple to remember, www.mhg's.mumbaihematologygroup.india.com. So if you didn't get a link, then this is the place to get your link. Tomorrow morning, we have Professor Nikita Mehra from Cancer Institute, Adyar, speaking to us on a rare subject, that is molecular pathogenesis, treatment and advances in not myeloma, but plasma cell leukemia. So I'm sure you all will look forward to it, especially if you are into hemato-oncology. As you know, we do Sunday quiz every Sunday. And like I mentioned last time, we invite you to take up this on your shoulder. If you think you can plan a quiz, you can come and conduct it on the Sunday using this platform. We also have a case presentation every Sunday. And you can also tell your stories, real life experiences, tough ones, tricky ones, failures, successes, and you can come and share this platform once again to share your story. What's most important is next week, Monday to Sunday, 6:30 p.m. to 9:30 p.m. IST. 3 lectures daily, 21 lectures by 21 international guest speakers, covering what was new in the 27th Congress of European Hematology Association, the EHA meeting. EHA meeting was hybrid. Unfortunately, we have not been able to do hybrid, so ours will be a web one. A lot of challenges were either answered or new challenges were created, and all that will be reviewed in these 21 lectures. So maybe finish your day work a bit early and log in at 6:30. Details are once again there at the website. Now we come to the talk of the day. That is 10 things that a hematologist I had initially written should not do, but then I changed it to must not do. And I must tell you that when I was preparing this 10, I got 50 things that a hematologist must not do. So we can have another 4 lectures of 10 each. And this one itself, though it says 10, but there are 13 already in this. So I will be putting up the questions to you. We are going to begin with the first entity which relates to surveillance PET scan. And the question is related to this case. A 48-year-old male, asymptomatic, earlier had DLBCL, stage 3B, IPI 3, received usual 6 cycles of R-CHOP, end of treatment PET scan showed complete metabolic response. So now, 6 months after this, he's asymptomatic and he wants to know whether he should undergo a PET scan to know whether there is a relapse of the disease or not. What would be your answer? Yes or no? So now you will have the option of voting, and then Kalpesh will show us your voting pattern. Over to Kalpesh. Okay. So approximately 3/4 of you will not be asking for the surveillance PET scan, and 1/4 of you will be asking. And now we open it up to all the friends that are present over here. I'll stop sharing for the minute so we can see everybody. All those who want to answer, participate, you can open your videos, just raise your hand and discuss. You don't want to say that you should do it, you discuss that. You want to get it done, discuss that. So you have Amit Kumar raising his hand. Amit, go ahead.
Good evening, sir. Basically, in the DLBCL or non-Hodgkin lymphoma, the early diagnosis in surveillance is not of, it is not showing any OS benefit. Even if the we are just following up the patient with routine blood test or physical examination every 3 monthly, there is no role of imaging in those group of patients. Even if the patient might have, if it's subclinical disease, so the benefit of treating those subclinical disease over when the patient developed clinical manifestation is not there. So we have to wait till the patient is either symptomatic or by clinical or physical examination we can get something.
Fine. So he justified it by saying that even if you can make an early pickup of the relapse, there is no survival advantage. Ankit? Ankit, we are not able to hear you somehow. Ankit, we can't hear you. Okay, Dr. Chepsi.
I think I'll agree with the previous suggestion, but just a rider here that yes, if there is any symptoms, we should not hesitate in doing it. We should go ahead and do a PET scan is what should be the ideal practice. But like you wrote, that it's asymptomatic it's really makes no benefit. I like you. But any hint of the symptoms, I would definitely suggest doing.
Right. For the first 1 year or 2 year, will you like to do it without symptoms, without any changes in the blood matters?
Sir, ideally in a practice.
Or would be there an individual case, if not this guy?
Because it depends on
individual case of very high risk of relapse, and you want to do that as a surveillance scan?
Theoretically, not supposed to do it, but I have done it. I have done it. Yeah.
So in practice, sometimes we do it. Dr. Verma.
Yes, yes.
Sir, like you mentioned, sir, for high-risk patients, there are retrospective studies which have shown that in a particular group of patients for initial 18 months, it may be helpful, like those who are IPI 3 or above. So that can be one group of patients where it can be tried. Right? But otherwise, overall, there is no such benefit. If you see, this is a particular group of patients. Sir.
Right. So yeah. So high-risk disease, more chance of relapses. You want to do it. Dr. Rajat.
Sir, I'm going to give you a pediatric flavor to it. Children are treated a bit differently from adults, and most of them will be Burkitt's lymphoma, and they get treated on a very intensive therapy, that will be LMB. The high-risk group, we will stage 3 high LDH or stage 4 bone marrow involvement, will add rituximab, because that's what the North American ANHL protocol showed. And majority of the disease will be abdominal. So we tend to just follow up with a ultrasound, especially in the high-risk ones, and the clinical examination every 3 months for the first year, but not a PET scan, And our relapse risk is actually extremely small in children because they get treated on a very very intensive therapy. They are mostly in patients for the first 4 or 5 months, and that's it. That's how the pediatric treatment, even without rituximab, the lower risk ones are actually cured. And to be honest, in our hospital, KK, in the last 15 years, we actually have only 1 relapse and 100% survival. It's a children's disease is way better than that. But we treat it differently. But I agree. Well, I had some adult hematology background also, so we wouldn't routine ones. No, maybe the high risk group with the hint of symptoms. Yes, we want to.
I saw Dinesh raising the hand. Has he withdrawn his hand? Dinesh Murani, where are you? Okay. Anybody else? Dr. Mukulia.
So my take is yes, for the high risk, PET scan every 6 monthly for first 18 to 24 months. And for almost all other cases, you do a good physical examination, do the screening clinical features for looking for symptoms, and probably an ultrasound abdomen to be done every 6 months.
Fair enough. Yeah. Okay. So I don't see any more raised hand signs. Okay. Yeah. Is it? None. Dr. Amrita.
Sir, what I think is in all cases of DLBCL itself is always a high-grade lymphoma. But if there are no clinical features of relapse, then obviously we see the patient, follow up the patient every 3 monthly, and then we do the routine blood tests and all. So if there are no clinical features of relapse, there is no rationale of doing a PET CT. Annual blood reports and all, including the thyroid function and other tests should be done. But I guess PET CT should only be reserved in cases where there are feature B symptoms coming back, or maybe if there are any features of marrow infiltration, as in the CBC getting affected. Otherwise, I would not want to get a PET CT done.
Okay, thank you. Last 2 remarks, one from Jyoti, one from Dinesh. Jyoti.
Sir, taking the IPI score and the DLBCL and the age of the patient, as per the NCCN guidelines, 6 monthly for the first 2 years should be done. In India, we may not be doing it, but as per the guidelines, the surveillance is part of the protocol, sir.
Right. And last remark from Dinesh. Dinesh, we see your hand raise sign. Do you want to participate?
Sorry. Can you hear me, sir?
Of course, we can hear you.
Can you hear me? Okay, sorry. So the NCCN says every 6 monthly CT scan. We can replace it with the PET scan, but in practicality, I don't think there is any benefit of doing the surveillance, and we are exposing to the radiation. So, apart from if you are worried about the relapses in a high risk, generally we don't do the any scans. So LDH yes, physical examination yes, the investigations yes, and nothing much.
Okay, so that was the question. And let me show you some of the literature now. So what you see in this particular cartoon is this shaded area here. So you got a patient who has got a disease here, the high burden, you put him into complete remission. And as you know, 40% of the patients are going to relapse. And this is the area which you probably will pick up with the radiology, and then patient will develop a disease. So there's a little bit of window here, which you will pick up. Now, does it impact the overall survival? And this study clearly shows you that the p-value is not significant. These are survival of patients who were picked up by PET, and this is survival of patients who were picked up by clinical sense. And the p-value is not significant, which I think almost 70 to 80% of our faculty said today. And 75% of the audience also voted. This is a systematic review of surveillance imaging in patients of DLBCL and Hodgkin lymphoma, 90% being DLBCL, 10% Hodgkin, of almost 3,000 plus cases from 15 studies. 20% of patients relapsed. 60% of these were identified by some other means than the surveillance imaging. That means clinical sense invariably. No report showed a survival advantage of those whose relapse was detected by PET. These data, along with the multiple other studies, indicate that there is insufficient support for routine surveillance PET scan in patients with DLBCL. Now, this is ESMO guideline, diffuse large B-cell lymphoma, about diagnosis, treatment, and follow-up. Now, what does it say? Careful history and physical examination, every 3 months for the first year, every 6 months for the next 2 years, and then every year after that. Mainly to look for development of secondary tumors and long-term side effects of the chemotherapy is recommended. Blood counts 3 months, 6 months, 12 months, 24 months, and then only if needed on suspicious symptom and sign, minimal radiological investigations. And you know, some of you quoted the NCCN guidelines. So there are some supporters. Minimum radiological investigations done at 6, 12, and 24 months after the end of the treatment by CT scan is a common practice. But there is no definitive evidence that this kind of routine imaging in patients who have achieved CR provides any outcome advantage. And this screening itself may increase the incidence of second cancer. Conclusion, routine surveillance with PET scan not recommended as per ESMO guidelines. This is Sarah Rutherford. He is from Cornell. And the conclusion of his presentation is evidence supports monitoring without surveillance imaging. Frequent scanning may identify early relapses, but there was no overall survival benefit. In fact, you will pick up false positive scans. And that is what you and me regularly see when we are very aggressive or a patient wants us to do it. And this false positive scan leads to psychological impact, anxiety. In fact, there is a study showing that 1 week before the PET is being done, the anxiety level went up by 100%. And then if it shows something, then there are unnecessary biopsies and complications related to biopsies. The radiation exposure that each PET scan gives you, even though it's a low dose CT scan with it, but it can significantly increase the risk of second cancer. And this risk is not hypothetical, it is real. And this is not a cost-effective strategy at all. So psychological impact, biopsy-related complication, radiation hazard with second cancer, and the cost. Novel monitoring strategies such as MRD detection by circulating tumor DNA, although in its early phase, could probably be a very good way to follow up the patients. This is American Journal of Hematology, striking high false positive surveillance PET scan amongst patients of DLBCL in rituximab era. So this false positive and then biopsy related complications. And this is R-CHOP or CHOP alone, 6 months to 36 months, striking high false positive surveillance PET scan to the tune of almost 25%, and even at the end of 3 years, 10%. This is Journal of Clinical Oncology doing a cost-effective analysis. And this is BJC, limited role of surveillance PET scan. And this is none other than the champion, Bruce Chezen, saying, routine surveillance scan are not indicated for patients with all sorts of large cell lymphoma. These are expensive, they are toxic, and they are anxiety provoking. They also have false positive results. They increase the risk of cancer, and they do not impact the patient outcome. Bruce Chezen. So there is no clear evidence to support surveillance scans. False positive in excess of 20%. And this is the calculation of the radiation hazard. Even with the low dose CT scan, 11 to 17 MSV, and a diagnostic contrast CT scan is 16 MSV. And these are the references for this kind of radiation hazard. So where do you do the PET CT scan in lymphoma? You do it for staging, Hodgkin, aggressive non-Hodgkin, early stage follicular if you want to treat with radiotherapy, if you're suspecting PTLD, and if you want to pick up a suitable site for biopsy in a low-grade lymphoma, and you're suspecting high-grade transformation. You do it for treatment response assessment like interim and end of the therapy. So this is PET2, this is PET3. You do PET2 for Hodgkin and aggressive NHL after 2 cycles. And if this is negative, then you need not do end of treatment. So PET3 is not required. Otherwise, PET3 in Hodgkin and aggressive NHL. And there are some other situations, miscellaneous. Assessment of response to second line or the subsequent of treatment. Prior to bone marrow transplant to assess the volume of the disease and suitability of the transplant. And then lastly, evaluation of symptomatic suspected relapse. So the answer is an emphatic no. So the learning point from the first quiz was routine surveillance scan in asymptomatic patient following curative intent treatment of DLBCL in a universal way, not indicated. We move to question 1B. Now we have a slightly different situation, that is chronic lymphocytic leukemia. So got a little younger patient, 56 years old female. She's asymptomatic. She was found to have been at stage A CLL. There are no comorbidities. And the question is, which of the following baseline surveillance imaging will you do? You'll do a sonography, you'll do a CT scan, you'll do a PET CT, you'll do a nuclear scan, or you will not do any one of these. So time starts now. We got the results now. 60% almost will not like to do anything, and 20% will like to do the sonography, and a small percentage, 13%, will like to do the CT scan. Very few will do a PET scan and a nuclear scan. Fine. So now we come to our faculty present over here. Raise hand sign and discuss. So we start with Amit again. Wow.
Yes. So in the case of CLL, if the patient is asymptomatic and binet stage A, in those groups, still we are following the patient only with a physical examination and the routine blood counts. Only if the patient is having some symptom, sometimes to do for rule out bulky disease, and ultrasound may be needed, but in routine practice, only physical examination we do.
No sonography, no CT scan, nothing. Okay, Dr. Verma.
Yes, sir. So all these investigations are not needed. Only thing is that chest X-rays will be done, which is clinically indicated, and otherwise physical examination.
Physical examination, X-ray chest, no other imaging. Prashant.
Yes, sir. Generally, I do a baseline chest X-ray and ultrasound. The chest X-ray basically to look for any mediastinal widening. Tomorrow, if he has bulky disease in a mediastinum 1. And other thing is there a coexisting infection there? That's one thing, because these are immunocompromised people. The ultrasound abdomen basically to see whether there is a bulky disease which is compressing on kidney or liver, porta hepatis. These are the things where, even though patient is low risk, we may have to intervene in some way. So that's why I just get a baseline done, and probably I repeat the ultrasound once a year under observation. That's all. No other imaging.
Right. So X-ray, everybody, sonography, 20% of audience, and Prashant described why exactly it is being done. Kunga.
Out of these, none of the investigation is required. Only X-ray, chest, and physical examination.
Fair enough. Dr. Nishant.
Sir, I think if the history and physical examination doesn't suggest that there is any symptom to suggest that that is a bulky disease, I think nothing is needed except a good physical examination and a history.
Fair enough. Dr. Amrita.
Sir, I think we are already given with the information that this is a Binet stage A, which means there must be less than 3 lymph nodes. So I don't think there is any rationale to do any further scans. We'll just do a 3-monthly or a 6-monthly CBC, and then see whether the platelets or the hemoglobin is dropping or the patient is developing any B symptoms. So I guess that's it.
Dr. Krishna.
No, so we don't do any. I don't do any imaging. Chest X-ray, maybe if there are any other symptoms which warrants a chest X-ray. From CLL point of view, no imaging in this situation.
Thank you, Dr. Jyoti.
Ma'am, so I agree with Dr. Amita. In Binet stage A, it's already given. We don't need to do any imaging.
Thank you, Dr. Priyanka.
I wouldn't even know if the patient does not have any symptoms of chest, like any shortness of breath, or if the patient does not have any RPI symptoms.
Thank you, Dr. Chepsi.
Yeah, I agree with all these suggestions, but most of the time these patients come to us through some other doctor. They are incidentally picked up, and by default, they would have already done it, even though we don't require it. But that is how the patients usually present to us through, they would have gone somewhere else and they would have done the screening and then come to us. So it doesn't harm them, but not.
So exactly like the audience, 20% said sonography, rest said nothing. I think our faculty over here has exactly answered like that. Occasional person said sonography, rest have said almost nothing. Before I come with few data, I want to put 2 more questions. One question is, how many of you do a lymph node biopsy? And second is, how many of you do a bone marrow trephine biopsy? This is not for the audience, it's only for the faculty. Yeah? So anybody. There are a lot of hand raised signs. I don't know if they're old ones or new ones. So anybody can take over.
Sir, Chepsi here, I do a bone marrow biopsy, but I don't do lymph node biopsy.
You do
but marrow, I do.
Uniformly 100% of CLL patients.
Yeah, I do practice like this.
Okay, fine.
Sir, Mukul here.
Yeah.
Sir, I do not do a bone marrow and lymph node biopsy for all my patients.
Neither of the two. Okay.
Neither of them.
Fair enough. Dr. Verma?
We do bone marrow only when the patient presents with cytopenias. Otherwise, routinely we are not doing. And lymph node biopsy we do not do for any patient. Only thing is when patient is having these symptoms, and if there are peripheral large lymph nodes or possibility of transformation, then only
suspecting transformation. Yeah. Who else is there? Dr. Krishna?
I don't do bone marrow biopsy unless there are any cytopenias. Lymph node biopsy only if the LDH is elevated and a PET scan is done and the maximum SUV area is selected, but not routinely.
Dr. Mukul?
Bone marrow biopsy only for unexplained cytopenia, anemia, which is not autoimmune in nature or not nutritional in nature, and thrombocytopenia if it is not responding to steroids. Otherwise, bone marrow not done. About lymph node biopsy, definitely no in almost all the cases unless we are suspecting a rectus.
Dr. Prashant?
Yeah, I do a lymph node biopsy only if there is an ultrasonographical feature that that show there is some caseation or something else, tell that coexisting TB or something like that. Otherwise, I don't do a lymph node biopsy. Bone marrow again, I don't do it unless there is a autoimmune cytopenia coexisting with that.
Okay, last.
Unexplained cytopenias is there. Previously, I used to do for every case, but now with the newer generations, and if there is only unexplained cytopenia, I am now doing. Otherwise, I am restricting to only peripheral blood cytometry.
Anyone else who wants to add or we go on? Okay. So that was the question. With a very early patient of CLL in at stage A, asymptomatic, no comorbidities, you were asked whether you would do any imaging. Chest X-ray was in fact not asked because that is sort of standard of care, at least in India, because of the tuberculosis as many mentioned. Even lymph node biopsy, they mentioned, at least one of the faculty mentioned that this is for excluding tuberculosis. So baseline surveillance CT scan in chronic lymphocytic leukemia. CT scan in CLL is not required for the initial evaluation. The staging of CLL is on physical examination and blood counts and never on CT scan. And large lymph nodes, if detected only on CT scan, do not change the Binet and the Rice stage. It has been shown that patients with Rice stage 0, but abnormal abdominal disease detected on the CT scan may have a more aggressive course. But you need more research to know whether only for that you do a CT scan as a routine initial investigation in patients of CLL. On the other hand, it has been demonstrated that most relapses or progression in CLL are detected by physical examination, blood counts, and not on imaging. The decision for relapse treatment was determined by imaging only in 1% of patients. And therefore, routine follow-up evaluation of CLL patient should not include CT scan. Additionally, repetitive CT scan once again are potentially harmful to the patient. In clinical trials where the treatment intent is to maximize the overall response rate, neck, chest, abdomen, pelvic CT scans are recommended to evaluate the response to therapy. So if you are looking at research data on any one of the drug, whether it's venetoclax or BTK inhibitor, they do regular CT scan, but the purpose is different. One CT scan should be performed before the start of the therapy, second CT scan at the final assessment. This is all in the research setting. For the assessment of the continuous therapy, like BTK inhibitor, CT scan should be performed at the time period of clinically evaluated maximum response. So this is in clinical trial, that is research. For students, please remember, this is not the standard of care in clinical practice. Except in patient with proven or suspected Richter transformation, PET scan do not provide information that is useful in the management of CLL. So we are now moving from CT to PET. Similarly, nuclear magnetic resonance imaging does not give you any more information. Ultrasound imaging, in some country, ultrasound imaging is done to assess the extent of lymphadenopathy and organomegaly, and it is reimbursed. Although ultrasound imaging may be very useful in individual patient, the results obtained by ultrasound are dependent on the method and the investigator. You could probably, with the probe being at one angle or the other angle, change the size of the lymph node, etc. So it's so subjective that it is not included in the clinical trials at all. This is baseline evaluation of patients of CLL at the time of treatment. So this is research, we'll leave that aside. This is clinical practice. NGI stands for not generally indicated. So CT scan, chest, abdomen, pelvis, NGI. MRI, PET scan, NGI. Abdominal ultrasound, possible, and the study has exactly indicated when. This is a radiologist speaking to you about the role of radiology in CLL. And what he says is taking years to become detectable, and unlike other types of cancers which provide solid masses, CLL is virtually invisible on conventional imaging, such as ultrasound, CT scan, MRI. As a result, imaging has a very small role in the management of CLL. We discussed about the additional two tests, bone marrow biopsy and lymph node biopsy. Lymph node biopsy is not required unless it is necessary for the research purpose. A lymph node or tissue biopsy is performed when you are suspecting register. A PET scan may tell you exactly which lymph node to biopsy. ASH recommendation: a patient of asymptomatic early stage CLL, baseline and routine surveillance CT scan do not increase the survival and are not necessary. It will expose the patient to radiation once again, and the cost is involved. Okay, so the answer is none, that is E, and I think 80% of the audience voted for that. So the learning point is don't perform baseline and routine surveillance CT scan in patients of asymptomatic early stage CLL. Move on to question 2. We are going away from the oncology now. So you have an 8-year-old boy. So we are in pediatric territory of Rajat. He is for elective surgery of cleft lip. He is otherwise healthy. There is no past and no family history of bleeding. Now the plastic surgeon is asking you CBC, platelet count and PT. We are talking about pre-op workup. Or CBC, platelet count, PT and PTT. Or CBC, platelet count, PT, PTT and a tag. Or just a tag, or none of the above. So please vote now. So you've got 5 things here. Now you can vote for any one of them. So option 2, that is CBC, platelet, PT, PTT, about 2/3 of the audience would like to do, and then there are small percentage, 16 will do none, etc., etc. So that's the voting pattern. 60% will like to do CBC, platelet, PT, PTT. So faculty here. So we start with Dr. Sanjeev.
So, sir, contrary to what the audience has told for what literature survey shows, that there is no indication for these routine tests in surgeries like cleft lip and palate in pediatric population. And multiple studies have shown that, especially if there is no family history, no past history of bleeding. So it is more of a psychological and financial burden on the family to get these tests done. And you can't predict complications very well by doing these tests also. So this is what I found on the literature survey. Thank you.
Sanjeev is for E, small group of audience. I think 16 to 18% had voted for that. Sanjeev is very emphatic. Okay, Ankur.
Sir, I totally agree with Sanjeev, sir. As per the British Committee for Standards in Hematology recommendations also, it is indiscriminate coagulation screening prior to surgery or other invasive procedures not required actually, especially when there is no past history and no family history, sir.
Fair enough. Dr. Rajat?
Interesting discussion on this. I agree. If you look at the BCHS guidelines, nothing is required. If somebody has taken a good history, personal history and family history. But I must say, even my hospital, KK Hospital, surgeons will routinely ask, I mean, it's being in practice. And the only thing I pick up is transient lupus. Very often we pick up a transient lupus anticoagulant and we'll end up doing all the according factors, 8, 9, 11, 12, 1 factor and lupus anticoagulant. And although I don't want to do it, but I'm sort of committed to do it, otherwise it will not happen. And so I agree you should not be doing it. But the common practice, I think the answer which audience have answered is that's the right thing to do. Well, only thing I would say, unfortunately, our hospital is a women's hospital also. So we use a lupus sensitive APTT reagent, which unfortunately picks up a lot of transient lupus, which is very common in children. So if I see that the child can wait for 4 months or 6 months for the surgery, I'll just repeat one and the raise APTT corrects. If it doesn't, or the child has to go for surgery, then I'll just get all the clotting factors done. But in absence of a bleeding history, have I ever picked up a significant bleeding condition? Answer is no. I have picked up a type 1 vulnerable disease, which is about to go to surgery, and then it was picked up. But then didn't make any clinical difference? Actually, no. So answer should be yes. We should not do any clotting screen if you're confident. But practically, it's still being done, and it causes more of a concern, unnecessary investigation rather than really any help.
Wonderful. So a lot of learning for the students, because this was a sort of voting pattern which was quite different. Okay, so Dr. Jyoti.
So I totally agree with the previous faculty. The guidelines and even the surgical reviews have found that it does not make a difference. In fact, very often we get patients where they have tested outside and adult range and pediatric range of APTT is a little different, and there's a panic in the family. Then you repeat it, you do a mixing study, and then you say, no, it's not normal for the pediatric range. Surgeons do tend to get a CBC and a APTT and a PT done. But the guidelines and the evidence says no need, sir, if you've taken a good patient history and family history.
So you're like the radiologist who said don't do radiology. Okay. Dr. Verma.
Yes, sir. So I also agree with the previous thought, sir. But only concern is sometimes we have seen patients of mild hemophilia getting missed and having more post-operative or perioperative bleeding. So I think from the surgical point of view, if the surgeon has given the review, that is another thing. But what we see on references and what we see in our patients in a clinical practice, sometimes we see that PT is more commonly done compared to APTT. But we have detected a few patients where mild to moderate hemophilia who never had any bleeding manifestation in past and got caught during this operative this thing. But otherwise, routinely not recommended. But 100%, everyone is doing this, and especially they do only PT and this bleeding time, and APTT is not recommended in any of the investigations. So that is one thing which is clinically we are seeing at this.
APTT is not asked for because Dr. Verma, surgeon, doesn't even know about what is PT. He only knows BT, CT, PT. Dr. Mukul.
So my take is slightly different from the previous speakers. Yes, we have our figures. We have detected patients who are post-surgery now detected to be mild hemophilia, moderate hemophilia, even VWD. I agree with you. I don't know why the fascination for PT is there amongst the general surgeons and everyone. Rather than PT, had your option been a CBC and a APTT, I would have definitely gone for that.
Okay, Amrita.
Sir, even I would differ over here a little bit. First of all, this is a child and a cleft lip. So this is a highly vascular area. So I think it does call for minimum baseline investigations. We have to check a platelet count. Second, I'm just differing a little over here, but a cleft lip or a cleft palate, in a child, you should always think about a syndrome like a DeGeorge syndrome or something, which may be associated with a bleeding disorder. So I think we should be checking a baseline PTA, PTT, and platelet count.
Thank you. Very different angle. Thank you, Chepsi.
Yeah, but practically
Missed out and we can't hear you. Okay, Prashant.
we in this scenario.
Yeah, Chepsi. Yeah, now we can hear you.
Yeah, sir. In this scenario, usually as a hematologist, we only get involved after the surgeon and the anesthetist have seen. And usually only if there's a derangement, they come to us. So practically the decisions are being influenced by the surgeon and the anesthetist's fear of complication. So in reality, in any center, I think it is being done. CBC, PTA, PTT is being done. And how much ever we might say, it probably needs the anesthetist and the surgeon's understanding for this practice to change. It leads to a lot of heartburn and a lot of waste of money. 100%. I agree with
Prashant.
Yes, sir. There are a lot of guidelines, but for me, practically, it took 10 years to make my lab discontinue BTCT. So it's a difficult scenario. A lot of the times you don't ask these investigations, rather you are asked to interpret these investigations which are already done. And the surgeon tells you give a fitness with the CBC and or maybe HBTC. A lot of the times it is HPTC, DC and a PT. If platelet is missing and APTT is missing there, and you are asked to give a fitness there. So when you are giving a fitness, you are giving a medical legal document that you are, yes, the child is fit. Then you are forced to do a platelet and a APTT invariably. Because I don't think any judge in this country would understand either British guidelines or American guidelines. So going by medical legal issues, a lot of the times we do a lot of unnecessary investigations. Going by last example, now the doctor was penalized for not doing an ultrasound guided thoracotomy and paracentesis. So we are in a difficult situation. So at least there are some basic minimum investigations. We will have to do it, whether we agree it or not.
Dr. Rajat.
Yeah, so the only two situations, or actually the one situation we do find bleeding to be a problem is adenotonsillectomy. That's still many children have that done, and that's actually the most hemostatic challenge in children. And we picked up mild hemophilias and vulnerable disease because of excessive bleeding, and actually it's a secondary hemorrhage. So that's a situation. Cleft lip, I'm not sure how important it will be, but adenotonsillectomy is probably the most hemostatic challenge operation in children. And MSA, yes, we have picked up mild hemophilias who have been bleeding, or vulnerable diseases have been bleeding after surgery, and clotting screen was not done before. So that's probably where the fear comes in. Yeah. But to be honest, in the eye of the law, I think we do have evidence to say that it's actually not necessary. So I don't think a doctor will be penalized by court if they don't do it, because we have the evidence to say that it's actually not necessary, provided you have been able to prove that you have taken the good family history and personal history and examination and so.
Thank you, Rajat. Priyanka, last.
Previous faculties that it's a routine practice for us to do the investigations requirements and like CPC, but it's not at all a routine practice. And for a child, I think history is definitely important, but since he's just 7-8 years of age, we might be missing this mild hemophilia and convoluted as discussed earlier. Also, that is a very good point. She brought out that she might be missing with some of the congenital disorders. So CBC with the peripheral smear comment is also very important. So this is a practice to investigate the patients with the minimum test. But that which is the assessment, the bleeding assessment tool which is taken up before we start investigating the patient is also equally important. So it's a practice, but guidelines are guidelines, and they have suggested that it may not be.
Thank you. I'm very glad that I included this in the discussion today, and I was a bit surprised when the audience voted. But after hearing about 10 of our colleagues, I do realize that there is a difference of opinion, and it's an important that we now come to the published guidelines, suggestions based on very, very strong evidence. And I agree with Dr. Rajat that in the court, it is the published guidelines. And if there are no guidelines, then the evidence. And if there are no evidence, then some large series. And then last thing is the experience of your colleagues who stand by you or don't stand by you. All that matters because the judge knows nothing about what coagulation means. Okay, so this was the question that you have a child, he's for surgery, and the surgeon is asking you, whatever you want to do, you do. You don't want to do, don't do anything, and you want to do any one of these, you do. He trusts you, you are his hematologist. And you go there and you take a good history, past, family, and you put that down in the paper that there is nothing to suggest a bleeding diathesis in his past 8 years and in the family. It's that kind of situation that you are discussing this, all right? Avoid routine preoperative hemostatic testing in an otherwise healthy child with no previous personal or family history of bleeding is the first recommendation. Rather than performing hemostatic testing on all, and some of the hospitals may have 30, 40 surgeries in a day, all pre-op pediatric patients, it is essential that rather than loading your lab with a lot of work, you spend 5 minutes with the family. Take a thorough personal, family, and the medication history related to abnormal bleeding signs or symptoms. This is because if the bleeding disorder is severe, like a severe hemophilia or Christmas disease, it will invariably be symptomatic. As was mentioned by more than one faculty, mild increase in PT or PTT, the commonest cause is transient lupus anticoagulant. And unnecessary your surgery of an admitted patient may get postponed, and that's not cost effective because operating a lupus anticoagulant will not lead to bleeding, and obviously because you did the test is abnormal, the surgery is postponed, patient is discharged, and you do elaborate workup, which is also expensive. There was a discussion about von Willebrand type 1. Now this comes under mild bleeding disorder, and there is a host of mild bleeding disorders. Now these mild disorders are not picked up on normal screening test. So whether you do platelet count, PT, PTT, TAG, mild disorders are not picked up. So in any case, you are not picking up mild bleeding disorders. In fact, if the history of previous bleeding diathesis in the child or the family, that may make you look for the mild bleeding disorders. Elaborate testing in the pre-surgical hemostatic evaluation of all the children is not cost effective. And lastly, this kind of delay in the surgery can sometimes have dire consequences. So these are very, very clear-cut guidelines published left and right. For last 15 years, one has to just have a look at it. And these are some of the references which you need to look at. Routine pre-op coagulation test in children undergoing elective surgery or invasive procedure. Are they necessary? 2019. The need for routine pre-op coagulation screening, prothrombin, partial thromboplastin time in healthy children undergoing elective tonsillectomy and or adenoidectomy, including what Rajat discussed, published 20 years ago. Perioperative management of hemostasis in children and adolescents. British Committee for Standards in Hematology Guideline on the Assessment of Bleeding Risk Prior to Surgery or Invasive Procedure, published 14 years ago. Routine pre-op coagulation test, an outdated practice, published in Anesthesia Journal. A cost-effective analysis of coagulation testing prior to tonsillectomy and adenoidectomy in children in pediatric journal 12 years ago. There's enough literature to support you that nothing needs to be done. So the answer is none of the above. The answer is E. Learning point is do not perform routine pre-op hemostatic test like PT, PTT in an otherwise healthy with no prior personal or family history of bleeding. And if there is, then screening tests are not enough. Then you need to go to tests like von Willebrand disease type 1 and so on, everything. Question 3A. 26-year-old female. Mild hemorrhagia for a year, now is seen for fatigue. And this fatigue is because of hemoglobin of 4.8. She's otherwise absolutely asymptomatic except for this fatigue. Her ferritin is 2. Her cardiorespiratory status is fully compensated, normal pulse, normal BP. We have been given 4 options for treating her. 26-year-old female, iron deficiency, hemoglobin 4.8, except for fatigue, asymptomatic, etiology of the iron deficiency, mild menorrhagia for a year, cardiovascular status fully compensated, normal pulse and BP. You'll give her IV iron 1K. You'll give her Paxil 2 bag followed by IV iron 1K. You'll give Paxil 2 bag and put her on oral iron therapy for a couple of months. Or you'll do her uterine thermoablation. Please vote. So we got about 58% saying that they will give IV iron. And then there is a couple of people who would give Paxil followed by iron, and some will give Paxil followed by oral iron. And immediate uterine thermoablation is a rarity. So that's the voting pattern. So now we will go to our faculty here. Chepsi.
So my practice, I would prefer to give IV iron upfront. That's what I do. I avoid a transfusion, especially if there's nothing else.
So no
I prefer to avoid a transfusion, give IV.
So you go with the majority of the audience. Yeah. Shishir.
I do not give a transfusion until unless means patient is hemodynamically unstable, especially means young people, we avoid transfusion. Definitely there is iron deficiency. If we give IV iron, means generally we have seen within a month, hemoglobin raised by around 4, and even within a week, hemoglobin raised by around 1.5 gram. So that is means sufficient enough. This is chronic anemia. I will say IV iron, that is justified.
Go with Chepsi, yeah. Nishad.
I will go with the participants. I would avoid transfusion unless the patient is hemodynamically compromised or there are some cardiac issues. IV iron is very, very effective, and we all know that the hemoglobin will start rising within a week's time.
Rajat.
Yeah, I agree. No need. This is a chronic anemia. This patient is well compensated. I'll tell you the pediatric perspective. I see in 2 situations this. One is the babies who have only milk, and then gradually they start to become iron deficient, and they usually by 18 months, 2 years, then somebody realizes he looks very, very fair, and then somebody realizes actually it's a severe anemia. And those are chronically iron deficient, so usually we just give IV iron. The other situation is adolescent girls. Very often they will have a menorrhagia when they start menarche, and it will go on, and they refuse to take oral iron somehow. And then they get into the situation of a chronic anemia. Both situations, IV iron, we have pharyngect, we just do the calculations. And I really have trouble in convincing my pediatric colleagues sometimes to say, do not give blood transfusion unless the child is symptomatic. They would try to say that the child is symptomatic and they're having different walking and that sort of thing. But it's just a matter of practice and convincing them. Do not give IV iron in these patients.
Right. So
they do not give IV blood transfusion. Sorry, just IV iron. And they should usually response reticulocytosis happens within a week. And I have a story of a little kid in Bristol Children's Hospital, UK, hemoglobin of 2.5. My consultant did not give blood transfusion. We repeated the blood count. Within a week, it came. So 2.5 was the lowest hemoglobin seen without a transfusion, just with iron.
Absolutely. Jyoti?
So totally agree with the others in the audience. It's a chronic iron deficiency anemia, well compensated, hemodynamically stable, only IV iron. The best blood transfusion is the one which is avoided in such a case.
Thank you. Anil?
Yeah, I agree with everybody. Just a comment that we now have a very standard practice. By the time report comes from my table, my staff is already preparing the iron, and I convince the guy, and he goes out into the daycare, takes the iron, and within 30 minutes is out. And these are the patients who are very rewarding, and they come back in a week, and the hemoglobin is good. They're full of smiles. They bring you more patients, and this is added to megaloblastic anemia as another thing which creates miracles, and they say, hey, you are the god. So that is how it is.
Okay, so 3 more responses, Radhika, then Ankur, and then Varma. Yeah, Radhika.
I agree with the previous speaker, sir. Patient is well compensated chronic anemia, no failure, hemodynamically stable. The transfusions are not a requirement here, sir.
Thank you. Ankur?
I totally agree with everyone. She's a young lady with IDA, fully compensated. It's better to avoid red cell transfusion for its potential for allogenization. When IV iron therapy can do the miracles. Thank you, sir.
Varma and Krishna. Yeah.
Yes, sir. No transfusion, only IV iron. Only thing is that the dose may be based on weight, maybe 1.5 gram, 750 on to 1 week apart. That is only thing.
Sure, absolutely. You need to calculate the, yeah, sure. Krishna?
So I agree with everybody. I mean, wherever there is a correctable anemia, I don't give blood transfusion. But my practice so far have been, they're not unstable. I give oral iron and they've been doing very well with oral iron. But now it seems like the concept has changed to IV iron. So I would like to learn from you. I mean, even if there are no contraindications like, gut disease or intolerance, should we be giving IV iron or a time-honored oral iron? Because I have found oral iron also is equally effective.
So at least there is some discussion. Otherwise, it was absolutely uniform opinion from everybody. So Nishad, okay, Nishad.
Sir, just one more comment. We get a very common consult for a pregnant patient with iron deficiency anemia. And even in these patients, IV iron works well, and there is enough data that IV iron is safe in pregnant patients.
Right, unless the patient has come on the day of delivery. So yeah. Even late 3rd trimester, you can manage. Absolutely. So I'll just share my screen now. So that was the question. IV iron versus blood and IV iron versus blood plus oral iron versus taking care of her menorrhagia. All right. So the question is blood transfusion versus iron. Basically, iron deficiency anemia is the commonest cause of anemia affecting 2 billion individuals worldwide. Iron deficiency anemia invariably develops over time. So it's invariably a chronic disease. Most patients are asymptomatic unless fatigue is the one you're talking about. Even with very low hemoglobin, as Rajat mentioned, 2.5 grams. The 2 key steps in managing iron are replacing iron therapy, which rapidly increases hemoglobin, everybody mentioned. Find out the underlying etiology, like again, the faculty discussed that. And this is very important, especially in the geriatric practice, because you may miss a major disease in the GI tract. Recommendation is against blood transfusion in asymptomatic patient with iron deficiency anemia who has no evidence of hemodynamic instability or active bleeding. Recent studies support, and that also was mentioned by faculty, that IV iron therapy using FCM or isomaltoside, because these 2 can be administered as almost like a total dose in one go, 15 minutes. Of course, Those who can tolerate and are compliant can be easily treated with oral iron therapy, as Krishna asked. And the present protocol is that you don't have to give it twice a day, large amount of iron. Low dose oral iron therapy given on alternate day is good enough. And that is because of, we are not discussing today, but the hepcidin metabolism. The more the iron you give, more hepcidin you produce, less is the absorption. So you only increase GI toxicity. So if I have a woman who says, I can't take iron, I give her half the dose after food, alternate day, and many will become compliant. So if you can tolerate, you are compliant, oral iron therapy can be done, but this has to go on for 4 to 6 months. So iron deficiency anemia in emergency department, there is an overuse of red cell transfusion, and our audience at least did mention that they will give transfusion plus iron, and that's the sort of algorithm here. So towards optimized practice, iron deficiency anemia clinical practice guideline published here. Iron absorption from supplements is greater with alternate day rather than giving it every day. Please mute yourself if you got a family around. Intravenous ferric carboxymaltose in iron deficiency anemia. So the answer was without any blood transfusion, preferably total dose iron in one go, A. So don't transfuse Paxil to iron deficiency anemia in an asymptomatic patient where there is no hemodynamic instability and there is no active bleeding. 3B, we have a patient of acute myeloblastic leukemia, 32-year-old male. He has just completed his high-dose ARA-C consolidation. He's got no cardiac problem. His hemoglobin is 6.5. So this is day 7. 6 days you gave this ARA-C. This is day 7, you got a hemoglobin of 6.5, or even day 8, 9, 10. How will you treat this patient now? You'll give Paxil 2 bag, you'll give Paxil 1 bag, you'll give IV iron 1K, you'll give injection erythropoietin, or you'll give 2 Paxil, IV iron 1K, and erythropoietin. So you've got 5 options: Paxil 2 bag, Paxil 1 bag, iron, EPO, or everything. So you vote now. So interesting, those 60%, 70% voting has disappeared. Now you got about 42% will give 1 Paxil, 26% will give 2 Paxil, and then the others. Okay. And we go now to the audience, our faculty. Dr. Radhika.
This is a chemo-induced anemia, sir. So AML first cycle of consolidation. I would like to manage this patient with 2 packed red cell transfusions, maintaining a hemoglobin of more than 8. So 6.5 HP with 2 Paxils, probably I'll reach 8.5. And that would be my approach here, sir. Obviously, IV iron I will not recommend here because it's not an iron deficiency anemia. Erythropoietin also not. For the pathogens is what is the cause for anemia. EPO is not the choice here, sir. So I would like to go for 2 packed red cell transfusions.
Nishad.
I think we have given myelosuppressive therapy to this patient. I will also treat this patient with 2 Paxil transfusions. I will use erythropoietin, only if there is persistent anemia despite the marrow recovery and there is persistent anemia.
Okay, so 2 Paxil plus maybe EPO. Priyanka.
For this patient, if the patient is in-house or hospitalized, then we try to maintain at 7 gram percent hemoglobin. So 1 would be sufficient. But if I am discharging the patient home, patient is stable and being discharged, then I would go for a 2 Paxil. And erythropoietin and all comes later, not in the acute management.
Yeah. We will move to Shishir. Priyanka, if you can improve your, we are not able to hear you well. So I forgot to tell you. Shishir, yeah.
Sir, number of PRC transfusion definitely depends on in which phase of recovery we are. like if we are somewhere around 15, 16 today, maybe just one transfusion that is sufficient. But if we are in 10th or 11th today, 2 PRC transfusion. And iron definitely not indicated, because means that this patient must have received a lot of transfusion during induction phase also. So iron deficiency must not be there until unless means he is having some unusual bleeding. And erythropoietin, few people had used erythropoietin, but generally it is not means effective, and virtually there are means some reports means erythropoietin may increase the leukemogenesis. So that should be avoided.
Thank you. We'll take 5 more comments. Ankit, followed by Amrita, followed by Yoga Lakshmi, followed by Nilesh, and then Krishna. That's it. Okay. Ankit.
Oh, sir. Yes, sir. Good evening. I hope I'm heard by. So earlier I was not able to speak. Sorry for that. So my concern would be that why this patient had anemia on day 6, day 7 of chemo, because like we know that high dose eracid, the effect will start after 7 or 10 days, and that too will be reflected by cytopenias in neutrophil and hemocyte lineage rather than anemia. So first question is whether the patient had any internal bleed or any occurred bleeding. So if the patient had bleeding, then we may have to give PCV transfusion without FFP or platelets. But if the patient does not have any bleed and it's isolated anemia, then I would give 2 PCV transfusion only, and that too because the patient is most probably on OPD basis visiting on a daycare facility, and better give transfusion at a single go to avoid frequent visits.
Thank you. Amrita.
So, sir, this is a patient with active malignancy on chemotherapy, and the guidelines say that we have to maintain the hemoglobin above 8 when the patient is on active chemotherapy, but also the BCSH guidelines say that we should be ordering 1 packed cell at a time. So I will not order for 2 packed cell. I will just order for 1 and see the hemoglobin increment and wait and see when the next cycle chemotherapy starts. If it is again less than 8 at the time of active chemotherapy, maybe another 1, but not 2 at a time. Again, there is no rationale for EPO because this is an active malignancy and we do not want to give erythropoietin then. And for iron deficiency, we have no evidence of iron deficiency anemia. This is clearly a disease, malignancy induced and a chemotherapy induced anemia.
Thank you. Dr. Yoga Lakshmi.
Sir, because this is an anemia of due to the myeloablative therapy or because of the disease per se, I would like to go for packed red blood cell transfusion. Whether 2 units or 1 unit, it may depend upon the patient's weight. If the patient is somewhat like around 45 kg like that, then maybe 1 transfusion will increase the hemoglobin to 8 gram, more than 8 gram. And if the patient is hefty, more than 75 kg, then better to go for 2 packed red cell transfusion. And there is no role of erythropoietin or IBI on.
Right. Agreed, weight is important. Yeah. Nilesh. Hi. Can't hear you. Unmute yourself.
Hi, sir. Hi, sir. So I would look for the cause of anemia here. If it is really chemotherapy induced or whether B12 or iron deficiency is also associated. So I'll order an anemia profile and we'll go ahead with the transfusion. And depending on that anemia profile, I'll take a call on supplementing with B12 or iron also.
Thank you. Thanks. Krishna, last remark.
So I'll give 2 units of PRBC, sir. 2 units of packed cells. Hello?
Yeah. Thank you. 2 units, yes. So we'll come to a little bit of discussion now. So here, unfortunately, the weight was not mentioned. I must say that should have been mentioned, which would have helped you in deciding between 1 bag and 2 bag. And also the day was not exactly mentioned. So there was some discussion, why did he develop anemia on day 7? But as far as the teaching part is concerned, the most important aspect of teaching So blood transfusion specialists use certain terminology. And the most important terminology they use is liberal transfusion strategy versus restrictive strategies. And I think that is very, very important. If you look at their literature, blood transfusion literature, this is very important. What it tells you is the smallest effective dose of Paxil as against liberal transfusion strategy, where you can give any amount of blood which you feel like. Unnecessary transfusion generates cost and potentially adverse effects. Hematologists are urged to avoid routine administration of 2 units if 1 unit is sufficient. And this is the modern thinking of restrictive strategy versus liberal transfusion strategy. Now, in a person who's got a hemoglobin of 6.5, and I'm sorry for not mentioning the weight, maybe a bag of Paxil will push this hemoglobin to 7.5. And that may be enough to buy time and wait and give the next unit after a couple of days. In the bargain, in the whole cycle, you may use 50% less Paxil. And we don't want to discuss just now about the platelet, but same may apply to the platelet, which will be cost saving, toxicity saving. Do not transfuse. So the learning point is do not transfuse more than the minimum number of Paxil necessary to relieve the symptoms of anemia, and to return the patient to a safe hemoglobin range, which is between 7 and 8. Unless you've got a cardiac status, the patient is stable, without any cardiac problem, hemoglobin in the range of 7 to 8 is enough. Question number 4. We're now going to sickle cell disease. 28-year-old male, sickler, usually his hemoglobin lifelong was 6.5 to 7. Now he's seen in the emergency department with VOC, vaso-occlusive crisis, and at that time his hemoglobin is 5.5 and his hemodynamical is stable. He was given pain management, hydration, oxygen. Now, which of the following will be your additional treatment? So he's a sickler, he's 28-year-old, his hemoglobin throughout his life has been 6.5 to 7, and this day it is 5.5. His hemodynamically stable. He gets oxygen, hydration, and pain management. What additional treatment will you give him? Cross-matched Paxil to raise his hemoglobin to 7. Paxil O negative without wasting time on cross-matching and making the hemoglobin 7. Not giving blood transfusion at all. Screening for red cell allo antibodies and then giving him duly cross-matched Paxil and making his hemoglobin 7. So I'll just repeat. Cross-match Paxil, push the hemoglobin to 7. Paxil O negative, not wasting time on cross-matching, making the hemoglobin 7. No Paxil at all. And the most elaborate way, screening for the red cell antibodies and giving duly cross-matched Paxil to raise his hemoglobin to 7. 4 options, please vote. Extremely interesting. 4th option, half of the people would like to be very careful. There is no emergency for them. 30% won't like to do anything, no Paxil at all. And 20% about will raise the hemoglobin by cross-matched blood to 7. And nobody will be rushing with the routine O negative business which you do in emergency. So we come to our faculty here. So Ankit.
Yes, sir. So as the patient's hemoglobin now was remaining 6.5 to 7 gram percentage, right? And it has dropped by maybe 1 gram percent during this current episode of acute occlusive crisis. Patient is hemodynamically stable and hope that symptoms are becoming better and better with hospital stay. So if the patient is stable and hemodynamically stable and becoming symptomatically better, then better to avoid any transfusion at all. So no transfusion.
Ankit says no transfusion. Amrita.
So the patient has come with a vaso-occlusive crisis, which means I will want to transfuse. Now, well, the baseline is 6.7 to 7. So I definitely would not want to raise the hemoglobin beyond 7. First thing is sickle cell patients are chronically transfused. So there's a very, very high likelihood of developing alloantibodies. Now, the International Collaboration for Transfusion Medicine, they have produced a guideline which has been published in the BCSH, now which has a low quality evidence but strong recommendation for checking each patient for alloantibodies before transfusing them in cases of sickle cell. Now, the question over here is whether we should be doing an exchange transfusion or a top-up transfusion. By no means we should be raising the hemoglobin beyond 7, but also we have to see that the sickle cell percentage has to be less than 30%. So I would say I will want to definitely cross-match for alloantibodies, but I will take a call whether I want to do an exchange transfusion or top-up, depending on the sickle cell percentage. And since the baseline hemoglobin is low, probably go for an exchange.
Thank you, Dr. Amrita. That was an interesting reply. We'll discuss this. We have 6 hands now, and we are running out of time. I want to have all 6 answers, but brief ones. So Rahul followed by Kundar. Rahul, unmute.
So given an opportunity, if the alloantibody screen is available, and I would also like to see if the patient has been transfused chronically earlier or patient was non-transfused. If the patient is non-transfused earlier, the risk of alloantibody would not be there, so I would not screen for it. If the patient has been transfused chronically, then I would screen for alloantibodies and try to keep a hemoglobin around 7.
Thank you. Kungar followed by Prashant.
The patient has been managed for vaso-occlusive crisis, so now no paired cell transfusion is required.
Not required at all. Prashant. And then Anil.
I would transfuse. As earlier told, if it is he's been repeatedly transfused, I would screen for alloantibodies, but I won't wait for the results. At least one packed cell I would transfuse upfront because there is a vaso-occlusive crisis. We need to relieve him.
Anil.
We don't know whether the response to the medical treatment of the vaso-occlusive crisis was effective. We have found that when you transfuse the patient, when the patient is severe vaso-occlusive crisis, the responses are very good. And sometimes the pain just goes away in the second day. So you have to keep that as a transfusion, as a treatment for the vaso-occlusive crisis as well, in addition to correcting the anemia.
Priyanka.
Sir, I agree with that. First, the vaso-occlusive crisis has to be managed in a way like the pain management and IV fluids and oxygen inhalation. If it is taken care of, then well and fine, we can wait, because once the crisis subsides, the number of hemolysis also subsides and it may rise automatically. The hemoglobin will rise up on its own. But if the patient still has VOCs going on, then there is definitely a need of transfusion. And in these cases, top-up transfusions are more important. Patients who have higher hemoglobin, there we need to go for an exchange transfusion. And if the patient has already been exposed to transfusion, then comes the thing of alloimmunization. We have to look into the alloimmunization and then do an extended phenotyping and transfuse the patient.
Right. Yoga Lakshmi, last one.
Sir, if the patient is improving on the current treatment, then there is no need to go for further transfusion.
Great. Fantastic discussion. There was a lot of variation, so that makes it interesting. Options were no packed cell, emergency transfusion without cross-match, with cross-match, or cold transfusion looking at alloantibodies, etc. Okay. This comes from the guidelines from USA. Please mute yourself. Ankit, please mute yourself. Okay. So patients with sickle cell disease are vulnerable to potential harm from unnecessary red cell transfusion. These are guidelines from the sickle cell from US, okay? They are vulnerable to unnecessary red cell transfusion. They experience alloimmunization to minor blood group antigen and also get iron loaded. Patients with most severe genotype of SCD with a baseline hemoglobin anywhere between 7 to 10 can usually tolerate further drop in their hemoglobin without developing symptoms. Now, during vaso-occlusive crisis, they all receive IV fluids to hydrate them, which contributes to further drop in hemoglobin by 1 gram and sometimes even 2 grams. Therefore, routine administration of red cell in this setting, where the patient has come for VOC and there is a drop in hemoglobin from his stable hemoglobin by 1 gram, should be avoided. Moreover, there is absolutely no evidence that blood transfusion reduces pain in a vaso-occlusive crisis. So the answer is, as per these guidelines published by the US Sickle Cell Society, no Paxil. Because we have a hemoglobin of 6.5 to 7 lifelong. Now it's 5.5. You're given the usual treatment for the vaso-occlusive crisis. You don't have to give Paxil. Okay, so we had a very fascinating discussion, I would say, and the voting. So do not routinely transfuse sickless for chronic anemia or uncomplicated painful crisis without there being an appropriate clinical indication is the learning point. I move on to question 5A. We are discussing ITP. 32-year-old female, chronic primary ITP for 7 years. In these 7 years, she has received steroids, IV gamma globulin and L-Trumbopag in past. For last 2 years, she's without treatment and her platelet count is around 70,000. She was now seen for a bruise over the knee and the platelet count was 40,000. What will you do? You'll give a steroid. You'll give a 1 dose of IV gamma followed by steroid. You will tell her that chronic 7 years, now you go for splenectomy. You'll restart L-Trumbopag and you will not do anything and just ask her to come back after 2-3 weeks. So you got 5 options. Last 2 years, no treatment, 72,000 around platelet count, now drops to about half of it, 40,000, and she got a bruise over the knee. You'll give a steroid, IV gamma with steroid, splenectomy, L-Trumbopag, don't do anything and ask her to come back after 2-3 weeks. So please vote. So 70% will send her back and ask her to come back after 2-3 weeks. So now our faculty here. And I can see the Prashanta will start. There are lots of signs. We have got about 8-9 of them. So please be quick if you want to.
I agree with the majority, sir. Wait for 2 weeks, see whether platelet rises on its own.
Call after 2 weeks. Priyanka?
Yes, sir. I'll also follow up the patient after 2 to 3 weeks. Just look at the platelet count. Chronic ITP do not require treatment as such if they are not bleeding.
Thank you. Ankit?
Yeah, I will agree with my colleague and the audience. No treatment as well.
Call after 2 weeks. Kunga?
Yes.
Asked to follow up after 2-3 weeks.
Radhika?
As per ASH guidelines, is observation and follow-up, sir. I'll call her after 2 weeks.
Mukul?
The same. Call after 2 weeks. Now, only thing is what could be the reason for this skin bleeding? At 40,000 platelet count, patient should ideally not bleed. So look for a history of any trauma, minor or otherwise, and if required, at the next visit, plan some additional workup.
Yeah, because that is absolutely good point, and I agree with you. A bruise over the knee. Knee is a totally exposed part of the body where there is no cover, and while walking, you may just hit the wall or a table, and with 40,000, a bruise can happen. So you are absolutely right. In the interest of time, is there anybody who has any different question or different opinion? If you all agree that just call after 2 weeks, then we can just move forward.
Sir, I pediatric perspective, I'll just tell one thing. We separate the platelet count. We don't take the platelet count into equation at all. Just look at the child, and we'll never treat unless there's a significant measurable hemorrhage. That's for pediatric perspective.
Fair enough. That's pediatrics, that you don't treat the count. Wonderful. So that was a slightly different opinion from the pediatric angle. Okay, so we'll just move on. Okay, so that was the different options, and I'll not read it again. So treatment of ITP should be aimed at treating and preventing bleeding episodes and improving the quality of life. Unnecessary treatment is hazardous, it has got side effect, it is costly with no clinical benefits. The decision to treat ITP should be based on individual symptom, bleeding risk, social factors like distance from the hospital, side effects of the possible treatment, upcoming procedures, and the patient's preference. In the pediatric setting, as Rajat said, treatment is usually not indicated in the absence of mucosal bleeding, regardless of the platelet count, as against in adult setting, where the treatment is indicated if the platelet count is very low. The definition of that is usually 20,000. However, ITP treatment is rarely indicated in adult patients above 30,000, unless you are preparing for surgery, invasive procedure, or there's some additional risk of bleeding. Patient preparing for surgery or other invasive procedure, short-term treatment may be required. So the answer in this patient was exactly what everybody said. Just ask her to follow up. And I hope in practice, everybody is doing that. Learning point is do not treat patient of ITP in the absence of bleeding or unless the platelet count is very low for adults and there is mucosal bleeding for pediatrics. 5B is a aplastic anemia patient, 15-year-old male, 2 months history, seen for hemoglobin of 4 and platelet count of 15,000. He's got symptoms of breathlessness and fatigue. There is no active bleeding. How will you treat? Paxil, platelet, both Paxil and platelet, neither of the two. Please vote. So 65% will just give Paxil and 20% will do nothing. Our faculty now. So we have got again 8 raise hand sign. So let's start. Please be brief, Ankit.
Yeah, so I'll go with PCV transfusion. Only that the patient is planned for transplant, then that PCV should be irradiated and lymphodepleted, and no PRCs to avoid exposure to multiple drugs.
Obviously, patient is not for transplant. The situation is only this much. Okay, right. Paxil alone. Radhika.
I'll consider packed red cell transfusions targeting a hemoglobin of more than 7, sir. No platelet transfusion unless until the patient has fever or bleeding.
So only Paxil. So now I will cut down the timing. So we've got about 10 more raise hand sign. So those who want to give only Paxil, fine, accepted. Those who want to differ, please go ahead. Okay, so we've got Dr. Verma.
Yes, sir. So only transfusion will be Paxil transfusion will be required because it's severe anemia. But the platelet transfusion is not required as patient is not bleeding and it is well above 10,000. Even with less than 10,000 also, if there is no bleeding, we do not transfuse the
Krishna, do you differ or just Paxil?
I usually, if I'm giving, in this case, I would give with platelets because there is a if you transfuse Paxil alone, and these are patients who can bleed suddenly. I would usually put platelet along with Paxil.
Paxil and platelet. So majority Paxil, occasional Paxil with platelet. Okay. So you had a hemoglobin of 4, platelet of 15. There was no active bleeding. An option where Paxil, platelet, both or none. Okay. So anemia is important. Bleeding, if it is taking place, especially at vital sites, it's important. The answer over here, as per the recommendation, is just Paxil, which I think majority of the audience said, majority of the faculty said. You don't want to keep giving platelet with 15,000 platelet and no bleeding because that will only create allosensitization. So do not give platelet transfusion to aplastic anemia in the absence of significant bleeding. Question 6. We've got now 70-year-old male. He's got chronic atrial fibrillation. He's on warfarin for 5 years. Now he is seen in the emergency department because his INR was found to be 7.2. He's not bleeding. So what action will you take? He's come to ED. You are the doctor in charge. INR is 7.2 for a person on warfarin for 5 years for chronic atrial fibrillation, 70-year-old. One, do not do anything. Just ask him to repeat INR release. Krishna, mute yourself. Second is admit and observe. Third is give vitamin K. Fourth is to give plasma. And fifth is to give prothrombin complex. Please vote. So half of the house says, just ask him to repeat INR, don't do anything else. 20% admit him. Another 20% give vitamin K. So now our faculty, we got 3 answers. Do nothing, repeat INR, admit, and give vitamin K. So we start with Radhika.
Sorry, sir. The patient does not have any significant bleeding. Probably I would just cease warfarin and give vitamin K, sir, and repeat INR.
So you will give vitamin K and then
yes.
repeat the INR.
And cease, yes, sir, and cease warfarin. No PCC or.
So those who are for vitamin K will stop here. Any different answer, Dr. Verma? Dr. Verma, you want to give any answer other than vitamin K? Okay, Ankit?
Yes, sir, I'll go with option A. List do nothing and observe. I'll obviously stop warfarin for the time being and repeat INR maybe 2 days.
So no vitamin K, observe. So we got 2 answers. One is give vitamin K and do INR. One is don't do anything, just do INR follow up. Any different answer? Anybody? Any different answer?
Stop vitamin K. Stop warfarin and observe. Admit and observe.
So that's the same answer which we got. So any different answer? One answer is vitamin K. One answer is only follow up INR.
So we have to go for the previous history. If there is any history of bleeding in past, definitely.
Yeah, take everything as negative. Whatever is there has been already put down.
So nothing much. Maximum means we can give vitamin K. And just
you are giving vitamin K, that has been answered. So any different answer, please? Amrita, Anil, Priyanka. Yeah.
Sir, I think this is an elderly person, so there is always an increased risk of bleeding. I will not send the patient home. I will want to at least keep the patient admitted and observed. Secondly, oral vitamin K, the guidelines say, the BCS says that if it is more than 8, then definitely give oral vitamin K. Between 5 to 8 INR, it is controversial. They say that consider vitamin K. So we never know why the INR is high since the patient has been taking for so long. Maybe there is the patient has been taking something which interferes with the vitamin K metabolism, warfarin metabolism or anything. So I would like to admit and observe and consider giving vitamin K and not giving vitamin K. That is not very clear.
All right. So we've got 3 answers by now. Admit, do nothing, follow up with INR and vitamin K. If you have a 4th answer, please go ahead. Faculty.
Sir, Sanjeevan here.
Yes,
sir,
sir.
I would like to transfuse in this patient, elderly person. INR unexplained, as was just mentioned, out of the blue, the INR has come up. I do not know the reason. I don't want to risk a bleed.
Plasma or prothrombin complex?
Because PCC may not be available at all the time, because that is, if it is available, if it is available, yes, definitely.
PCC. And by the way, PCC is available in India, courtesy INTAS.
Yes.
Okay. Any different answer? We got 4 answers already now. Any other answer? Otherwise, we move.
Sir, I agree with the answers, but there's only one thing that atrial fibrillation, we've had this issue many often. They are on these amiodarone, which may be causing increasing the effect of warfarin. So that history of amiodarone needs to be taken, because that has an issue. So that is the Fab4 when we always say fluconazole, amiodarone, vesitracin, and Flagyl to be.
Yeah, you'll find out the cause of raised INR.
Yes, in atrial, because it's an elderly with atrial fibrillation, they are very often on amiodarone.
Sure, I mean,
so that's there. Otherwise, the option is the same as the others.
Okay. Anybody else? We'll discuss only the issues which have been raised in this quiz. Okay, probably nothing. So we will move on now. So blood products can cause serious harm to patients. They are costly, and they are rarely indicated for reversing the effect of warfarin. In non-emergent situations, elevated INR is best addressed by just holding the drug and or administering vitamin K, as Dr. Amrita said, those cutoffs. So the answer is to avoid FFP, avoid prothrombin complex. This is a non-emergency situation. Best is to just hold on warfarin plus minus vitamin K, that she discussed it beautifully. So all this is well known, the intensity of anticoagulation and very narrow window between allowing the thrombosis to take place versus hemorrhage. So if there is a mild bleeding, skip warfarin till the INR just drops down to below 2. And severe bleeding, life-threatening, give PCC. And if you don't have PCC, fresh frozen plasma. So Sanjeevan discussed this, but the situation was not like this. And moderate is in between, where you give vitamin K. And if there is a life-threatening bleeding on warfarin, there are various things that you do: supportive care, reverse the effect, and attempt to stop the bleeding. And this discussion between PCC and plasma, which Sanjeevan raised, is a real one, and only hematologist can help you in this situation. And preferred is PCC. Only if you don't have it, then plasma. So the answer in this patient was there is no bleeding at all. Don't do anything, repeat INR, and as Amrita discussed, maybe yes, no, but vitamin K. So that's what the guidelines mentions. So do not administer FFP, do not administer prothrombin complex. It's non-emergent for reversing the effect of vitamin K outside the setting of a significant major bleeding or IC bleeding, or patient is going for surgery. The next question is 42-year-old male, road traffic accident, admitted after 2 days with fracture femur and a DVT. There's no past or family history of VTE. He has been started on anticoagulation. Which of the following will be your action before you allow the anticoagulation to be started? Collect the blood for full thrombophilia profile, collect the blood for acquired prothrombotic disorder, collect the blood for inherited prothrombotic disorder, do CBC, platelet count, PT, PTT, and TEG. Do nothing, just start anticoagulation. So you got a guy who is youngish, 42, road traffic accident. After 2 days, he's got a fracture and DVT is also found. There's no background of VTE. He's to be started on anticoagulation. You'll do full thrombophilia profile for acquired prothrombotic disorder, for inherited prothrombotic disorder. You'll do CBC, platelet, PT, PTT, and TEG, or you'll do nothing and allow the anticoagulation to take place. So we'll see the voting pattern from the audience. So we've got 65% say do nothing, just start anticoagulation. 17% are doing CBC, platelet, PT, PTT, and TEG. 10% are doing full thrombophilia profile. So our faculty now. So again, a lot of hand raise. So Shishir will start, and those who agree with him will remove their hand raise sign. Shishir.
This is some sort of induced thrombosis, so no workup is required. and we have to just give an anticoagulation.
Okay, so there's a trigger, there is no background, so just give the treatment, no workup. So those who agree with him, we need not have another discussion. Those who differ, yes, Ankit.
I agree in principle with previous speaker, but then before starting any anticoagulation, we have to do baseline tests. So if the patient is most probably starting on LMWH, then CBC, PT, ABDT, creatinine, obviously, that at least we should do, not from thrombophilia point of view, but from point of view of further monitoring and dose adjustment.
Okay. So the second suggestion is some baseline workup is needed because you're putting the patient on anticoagulation. So except these two, anything else, Radhika?
No, sir. I agree with the previous speakers.
Right. So that gives us permission to move forward. So thrombophilia screening, clinical evaluation, everybody. You must do, like we talked about bleeder. Thrombophilia testing only in select group. Not required if you are age above 60. Not required if it is a first VTE clearly provoked by a trigger like this patient is a first VTE and there is a trigger. Before estrogen prescription if negative personal or family history and if there is no descendant. Thrombophilia testing is costly, can result in harm to the patient because based on that you may change the duration of anticoagulation and usually you go to an inappropriately long treatment and the patient gets incorrectly labeled as thrombophilic. Thrombophilia testing does not change the management of VTE occurring in the setting of a major transient VTE risk factor. When VTE occurs in the setting of pregnancy or hormonal therapy, or when there is a strong family history plus a major transient risk factor, the role of thrombophilia testing is complex and a hematologist has to take the call. In this particular patient, what Ankit said, I bit agree. Otherwise, except for that, do nothing. At least do not do thrombophilia profile for acquired, inherited, or total. So do nothing and start anticoagulation, or you may do the baseline workup and give this. This is the guideline. So do not do tests for thrombophilia, at least in adult patients with VTE occurring in the setting of major transient risk factor like surgery, trauma, or prolonged immobility. 7B is 11-year-old boy admitted for a catheter-related thrombosis. No past history, no family history. The options are same which were for the previous patient. For 11-year-old boy, catheter-related thrombosis, no past history, what will you do? So you've got a younger boy now, pediatric set. So same 5 options. Let's see the voting pattern. So again, 60% say nothing, 30% do those routine workup. So our faculty now, maybe Rajat will also contribute for this case. Yes, I can see his hand raised. Start with Nishad.
I would do nothing except for some basic tests like CBC.
Okay, so you agree with the audience.
It's a catheter related case.
Yeah. Difference, Ankit?
No, sir.
No difference. Rajat?
No difference, sir. I just wanted to mention people, for the juries to remember Rishor's triad. That's all. You can apply to any thrombosis. So here, the 11-year-old child probably has developed a thrombosis because he's sick, and in probably in ICU for some reason. So has a catheter which is into the plastic, so slowing down the blood flow and causing endothelial damage. And probably this kid has a raised factor VIII causing the thrombosis. So when you do thrombophilia screening, remember you're just testing the increase, the constituents of. So in these cases, we wouldn't routinely test. I just want to mention 2 trials which are running in North America, the KIDS trial, which is looking at shortening the duration of anticoagulation. So we usually will take out the catheter and give 6 weeks of anticoagulation. Question is whether 6 weeks is enough or you have to give 3 months. That's one thing. And second thing is pediatrics, we always routinely do the anti-10A level. But again, another trial in North America called the Fix-It trial, which is just going to try and look at the dose-based, weight-based dosing and not do anti-TNA. Because I think anti-TNA is not available in many hospitals in India. So, so in pediatrics also there's an effort to move away from doing anti-TNA measurements. Answer was the same.
Thank you. We got two more raise hand sign, Prashanta and Dr. Thaligavanti.
Yeah, answer would be the same, sir. But I would be curious to know why this 11-year-old boy had a catheter. Because a lot of the times that diagnosis itself may explain the thrombosis per se, and we don't have to do anything.
So catheter needed in a child is there are many indications which we will not discuss, and catheter is also quite common problem. Okay, we'll probably leave that aside because that is not the topic for discussion. And last comment from Dr. Thaligavanti. Before she unmutes herself, Dr. Amrita, you have something to say?
Do nothing and start a child on anticoagulation for 6 weeks minimum, sir.
The options given to you and the guidelines say exactly do none of this. So we'll move on. We've got 3 more situations left and we'll try to finish in 10 minutes. So you got a 42-year-old man, iliofemoral DVT on day 3 of a major pelvic surgery. No past history, no family history. He's being discharged on day 10 on warfarin with INR of 2.5. Now this is the duration of warfarin therapy for this gentleman, 42. First episode, there's a trigger factor. His INR is in the therapeutic range. Will you ask him to continue warfarin therapy for 6 weeks, 3 months, 6 months, 1 year, or for a longer period? So please vote. 6 weeks, 3 months, 6 months, 1 year, or for the longer period. So option 2 is 70%, 3 months is the answer from the audience. Now faculty here. So those who agree 3 months, I think we'll stop there. Those who differ, let us answer. We can start with Amrita, then Ankit, then Nishad, Radhika, Rahul.
Sir, I'll agree with 3 months. This is a provoked condition. So we have no reason to continue long-term anticoagulant. There is no evidence of a lupus anticoagulant or no history of unprovoked. Again, no history of malignancy in which we give it for 6 months. But one thing I would like to say that at the end of 3 months, before stopping therapy, I think we should assess the DASH score to see, look at the D-dimer and all to see if it is safe to stop anticoagulation.
Ankit, if you differ from Amrita.
I agree with Amrita, but then the only thing is that if the patient had iliofemoral thrombosis, whether we had ruled out a IVC extension of the thrombosis, if the thrombosis was extending into IVC, then I would go for a 6-month therapy or even catheter-guided thrombolysis. If the patient had not been post-operative, yes.
Okay. A different answer from these two. Then Nishad.
Same, sir, no difference.
Same. Okay, Radhika.
It's the same, sir. 3 months duration.
Okay. I'm just hurrying up. I apologize because we must try 995. Okay. So those were the options given to you. And yeah, so initial management is done for about 3 weeks. Primary treatment goes on for about 3 to 6 months. And there should be reason for anything beyond that. So you got a provoked situation, it is 3 to 6 months. If it's idiopathic, you may require indefinite. And then there is a huge gray zone in between, which we'll not discuss. So anticoagulation is a harmful and costly treatment. Patient with first VTE having a trigger, surgery, trauma, catheter are at very low risk of recurrence. Evidence-based and consensus guidelines recommend 3 months, which the audience said, which our faculty said. By ensuring patient receives an appropriate duration of anticoagulation, clinicians may avoid unnecessary harm, reduce the cost, and improve the quality of care. This recommendation is not meant to be applied to VTE associated with non-major risk factor, hormonal therapy, pregnancy, travel-associated immobility, etc. So answer here was 3 months B. Learning point is do not treat with an anticoagulation for more than 3 months in a patient with first VTE, which occurs in the setting of major transient risk factor. Question number 9. 56-year-old male, bilateral lower limb iliofemoral DVT of 2 years standing. Patient has significant post-thrombotic syndrome with ankle ulcers. Investigations show that he is heterozygous for factor V later mutation, is homozygous for MTHFR mutation, there is hyperhomocystinemia, he also has dyslipidemia, hypertension, type 2 diabetes, and he has been on anticoagulation for these 2 years. He now has undergone an angioplasty, there are 2 stents, and he's been put on antiplatelet agents. What will be your action as a hematologist? You will stop his anticoagulation and put an IVC filter. We are talking about in the setting that he's got under angioplasty and now he's on 2 antiplatelet agents. You'll stop anticoagulation and you'll put an IVC filter. You'll stop anticoagulation and put a retrievable IVC filter. You'll continue anticoagulation but decrease its intensity and continue with those 2 antiplatelet agents. Or you'll stop anticoagulation until the cardiologist takes him off antiplatelet agents. Please vote. So 71% say continue anticoagulation with decreased intensity and allow the cardiologist to use 2 antiplatelet agents. And some say that stop anticoagulation until he's off antiplatelets. Okay, so faculty now. Ankit?
Yes, sir. So before those tents were put, I would have suggested that he go, or the cardiologist rather go for a bare metal stent, because in bare metal stent we can forego dual antiplatelets, and after 15 days, initial 15 days, patient can be kept on a single antiplatelet. In that case, patient may be continued on a full dose anticoagulation, which he has been already taking, along with clopidogrel, and we can avoid the aspirin and decrease the chance of especially GI bleeding and any other major bleeding episode. The patient has already put drug-eluting stent, for which 6 months of dual antiplatelets is required. Otherwise, the stent may occlude. So in that case, we have to decrease the intensity of anticoagulation. If the patient was, say, on rivaroxaban and he was on 20 mg OD, then we can cut down to 10 mg OD, prophylactic dose or a maintenance dose if it is available. If it is not available, maybe switch to another NOAC or any other therapy where we can cut down the dose with as per the guidelines and continue on dual antiplatelets.
That's quite elaborate answer. If you have the same answer, please we'll skip it. Otherwise, Khungar, Jyoti, Amrita, Anil, 4 hands are there. So start with Khungar.
So I will go with option C. We should continue with the anticoagulation with decreased intensity along with the antiplatelet agents.
All right. Dr. Amrita?
Sir, same answer. I will definitely not consider IVC filter because IVC filter is only for people in which who are not eligible for anticoagulation, like impending major surgery or in pregnancy with an impending delivery where we cannot give anticoagulation. Now, this is a high thrombotic risk patient, so it is not safe to stop anticoagulation. So I will decrease the intensity of the anticoagulation and start an oral antiplatelet.
Thank you. Anil, anything different?
Just a question which comes into mind that if you give full dose anticoagulation, do you still require antiplatelet agents after angioplasty? My question is.
Sorry, sir. There's one thing I missed. Since this patient is a cardiac patient, if we have to calculate the CHAD score, then I think hypertension is there, diabetes is there, congestive heart failure, age is there. I think it's coming to three factors are there. So anticoagulation definitely has to be given. I think more than 2, we cannot, it is an indication for anticoagulation.
Fair enough. I don't see any more hands. Okay, so we'll move on. This situation was basically exactly to discuss the filter business. So you got these IVC filters, which were very popular when I was young, but these filters have deadly complications. So IVC filters are costly, they can cause harm, they do not have a strong evidence-based indication. The main indication is for patients who have got acute VTE. Our patient was a chronic one. And if this patient cannot be given anticoagulation due to active bleeding or a high risk of anticoagulation-induced bleeding. Lesser indication that may be reasonable in some cases include patient who got pulmonary embolism despite appropriate therapeutic anticoagulation, or patients with massive pulmonary embolism and poor cardiopulmonary reserve. Retrievable filters are recommended over permanent filters with removal of the filter when that situation disappears. So answer in this patient is continue anticoagulation of decreased intensity and give antiplatelet agents as per the guidelines. And as all of you said, no filter any type, and you cannot stop anticoagulation in this patient. So everybody was perfect. Do not use IVC filter too liberally and on the drop of hat. So we come to the last situation, and we are going to finish by 9:10. So we're going to know an elderly man, CABG, post-op, he has got pneumonia. He landed up with intubation, and in this situation, he was transferred to us. He has been on heparin. His platelet count on day 1 was 200,000, and the same on day 2 was 9,000. No evidence of thrombosis, venous or arterial. So it was thought of, which of the following will be the most appropriate action? Do the lab test for HIT and continue heparin till you get the report. And we presume that report will be very quick. Test for HIT, stop heparin till you get the report and switch over to an alternative anticoagulant. And C is do not send blood test for HIT at all. So do the test for HIT, continue heparin, stop and switch over to a safer anticoagulant, or do not send the test for HIT. Just 3 options, please vote. So fascinating. You're going to divide house from the audience. 44%, they will send the test for HIT, stop heparin and switch over to a safer one. 35% don't want to send the test for the HIT. And a small percentage will send the test but continue heparin. Heart in heart, they didn't believe this is HIT. Okay. One fantastic, I would say. If we want this kind of discrepancy to discuss. So we have got raised hands. 1, 2, 3, 4, 5. 5 raised hands. So last question anyway. So let everybody have a good chance. Amrita.
I will not send the test for HIT. If you do the 40 score, the score is 0. The timing of thrombocytopenia is not between 5 to 14 days. Thrombocytopenia, usually in HIT, it becomes half of the original platelet count. It usually stays above 30,000, 20 to 30,000. There is no history of thrombosis. The platelet count is way too low for HIT. Fourthly, there is another possible cause of thrombocytopenia, which is sepsis. Again, one thing I would like to say, we do not have a history of previous history of unfractionated heparin, in which thrombocytopenia can occur earlier than day 5 if it is given within 100 days. So since that history is not there, I'm assuming it was not given and this is not HIT, I will not send test for it.
Thank you, Amrita. So if you agree with her, please need not discuss. If you disagree, go ahead. Jyoti, you disagree, go ahead. Unmute yourself.
I agree with her. I was just about to remove my hand because the 40 score is low at this juncture, even that within 1 day guidelines the symptoms are not there of that acute hit. So as per this, if we do the antibody hit test, that's what some people do. We may have a false positive and just create havoc. So in this, not recommended to send hit tests.
Okay, so fantastic. And I must say, brilliant reply by Amrita. Very comprehensive, detailed, fantastic reply. So calculate the 4T score is important. In patients with suspected hit, one must look at the 4T score to calculate the pre-test probability of hit. And for the students, this scoring system is based on 4 parameters: timing of thrombocytopenia, and Dr. Amrita and Dr. Jyoti discussed that, the degree of thrombocytopenia, presence and absence of clinical thrombosis, and existence of other cause of thrombocytopenia. Hit can be excluded by low pre-test probability when the score is anything less than 3. And in that situation, you do not have to send even the test. Not to discontinue heparin, not to start a non-heparin anticoagulant if your score is less than 3, because presumptive treatment often results into increased risk of bleeding and also expenses of an alternative anticoagulant. Ultimately, heparin is the cheapest. So in our patient, what was the score? Our patient had a score of 2 because he did have a drop in platelet count of more than 50%. But the timing was less than 4, so 0. Thrombosis, there was none, so 0. And other cause for thrombocytopenia, as Amrita again mentioned, pneumonia sepsis was there. So calculate the 4T score, and if your probability is 0 to 3 like our patient, do not send the hit test and continue with heparin. So that was the answer. And do not send the test for hit was the answer. So I think that's all what we have. Learning point was, do not test or treat for suspected hit in patients with low pre-test probability of hit. So I draw my conclusions here. What we did today was something which I hope I can go to the previous slide because I wanted to show that slide. Okay, anyway, in this mode we will see this. No, it's not happening. So no surveillance scans for DLBCL, no PET-CT scan for CLL, no preoperative hemostatic testing. Do not overdo blood transfusion. Do not give blood transfusion when iron therapy is adequate. Not to routinely transfuse sicklers. Not to treat ITP without specific indication. Not to give platelets to aplastic anemia liberally. Not to give plasma or PCC for reversing INR without clinical bleeding. Not to do unnecessary thrombophilia testing. Do not give anticoagulation for unnecessary prolonged period. Do not use IVC filters liberally, and do not do inappropriate hit testing is the summary of what we discussed today. So I hope hematologists will use the test judiciously. Yeah. Okay. Yes, Ankit.
Yes, sir. I have one comment to make about the last test. When we score for hit, if the nadir is less than 10,000, like this patient, then the score would be 0. So there are certain caveats in thrombocytopenia calculation also. If the platelet drop is more than 50,000, then the nadir should be more than 50%, then nadir should be more than 20,000. If it is less than 10,000.
Actually, Amrita had mentioned that, and it was there on one of the slide also.
Yeah.
Just the interest of time, we just skipped it. But yes, Amrita had mentioned it. Sure. Anybody else wants to discuss anything about what we did today? Of course, we are short of time.
Just a question. What should be the duration of anticoagulation in patients who develop thrombosis with autoimmune hemolytic anemia?
thrombosis with autoimmune hemolytic anemia. I presume you are talking about a chronic autoimmune hemolytic anemia, which is refractory to treatment.
The patient presents with acute autoimmune hemolytic anemia and also has a cerebral thrombosis. So we put them on anticoagulation and autoimmune goes into remission. So how long do we?
Cerebral thrombosis is 6 months.
6 months.
Primary or secondary. And here your disease has got controlled. Anybody else wants to say anything? So there are some comments. I'm happy to read them out. It was wonderful discussion. Nice to have interaction. Good night. Happy weekend. Nice meeting. Got to learn, relearn many things. Thank you very much. Okay. Right. Hand over to Manoj. Dr. Manoj from India. Yeah.
Thank you, sir, for this wonderful, wonderful session today. 10 things that a hematologist must not do. And I think I would request you to have just once, if it could be circulated, those 10 points we summarized at the end of your session, that would be just wonderful. I would like to add the 11th one, how to have a wonderful meeting, start on time and finish on time. That was the 11th learning for all of us. I can't thank all the discussions personally because there were almost 35 of them. And all those 25 countries which did participate today, they were just amazing. The interactions was lovely. All of you have a wonderful weekend. And once again, a big thank you to Professor Dr. MB Agarwal, sir, and all the discussions were there today.
Thank you. On behalf of Mumbai Hematology Group, thank you to everybody. Thank you.
Thank you.
Thank you.
Thank you so much.
Thank you.